In this video, I'll talk about the basics of Doppler ultrasound as it pertains to nephrology-related point-of-care ultrasonography. And the Doppler effect enables ultrasound to be used to detect and quantify blood flow. It is based on the frequency shift between a moving sound source and the observer. When the object is stationary, the reflected frequency or the frequency of the echo returning from that object will be pretty much same as the frequency emitted by the probe, that is, the transmitted frequency. When an object, for example RBC in the blood vessel, moves towards the transducer, the reflected frequency is higher than that of the transmitted frequency. And this is represented in shades of red color on the monitor. And when the RBC is moving away from the transducer, the reflected frequency is lower than that of the transmitted frequency. And this is represented in blue colors or shades of blue on the monitor when you are in the color Doppler mode. And the difference between transmitted and reflected frequencies is called the Doppler shift. There are different modes of Doppler that we use, and each serves a different purpose. The first thing is the color Doppler. When you hit the color Doppler button, it gives you the image with the red and blue colors if there is flow in that region of interest. And so essentially it tells you if there is any flow in the area, and if there is, what is its direction. So red represents towards the probe and blue represents away from the probe. This is the color Doppler image of the normal kidney. And the next one is power Doppler. Power Doppler depends on the strength of the returning signal instead of the frequency shift. And it is usually only in like one color, like yellow or orangish, something like this, but of varying intensities. At some places it's darker, some places it's lighter. And it does not tell you the direction of flow, and it is useful for low flow states. This is the power Doppler image of the kidney, but more than the kidney, it's useful when you are examining low flow states. Say for example, if you want to drain an abscess and you want to know if there is a small blood vessel in the pathway of your scalpel, you can use the power Doppler mode to look at the flow. And the third mode is the spectral Doppler. Spectral Doppler displays the blood flow measurements in the form of a graph like this. And it's used to measure blood velocities in the vessel. So this is the velocity scale in centimeters per second. So this graph represents the velocity of the blood in the blood vessel of interest. And there are two types of spectral Doppler: continuous wave Doppler and pulsed wave Doppler, which we will talk about in a bit. And other thing is that you probably heard the term duplex ultrasound. What is it? It's just a combination of Doppler image and the underlying grayscale image. So you have the original grayscale image of the kidney, and on top of that you applied color. So this is the duplex ultrasound. And if you apply spectral Doppler on top of your color image, like this, you already have a grayscale here. On top of that you have color. And again, now you are using the spectral Doppler mode to calculate the velocities to give you a graph. So there are three different entities here. That's why this image, you can say it is a triplex ultrasound. So that's what these terms mean. Now that we know the basic principle, we will look into the Doppler shift in little more detail. So Doppler shift is the difference between transmitted and reflected frequencies. It is given by the formula that is the difference between reflected and transmitted frequencies is equal to 2 times the transmitted frequency multiplied by V, that is velocity of the blood, and cosine of theta, divided by C, that is velocity of sound in the tissue. Theta represents the angle between the ultrasound beam and the direction of blood flow. So the Doppler shift essentially depends on the velocity of the blood, the angle between the beam and the blood flow, and the speed of sound in the tissue. Speed of sound in the tissue is assumed to be constant at 1540 meters per second for all practical purposes. Another important thing to notice here is that it's significantly dependent on this angle, and cosine of 90 degrees is 0. That means if the angle is 90 degrees, essentially all this thing will become 0, and it corresponds to minimum Doppler shift. At 90 degrees angle, you pretty much don't have any Doppler shift, and that means minimal color flow will be displayed in the vessel. And the cosine of 0 is 1. That means at the angles of 0 degrees, or when the probe is parallel to the blood vessel, you will have maximum Doppler shift. That means ideally the probe should be parallel to the vessel to elicit maximum frequency shift like this. The probe and the blood vessel angle should be like this ideally. But you can't always do this practically. You can't put the probe in front of the blood vessel. So for practical considerations, we say angle of 60 degrees or less to be acceptable when measuring velocities. And this is the bad angle. This is the 90 degrees angle, so you'll have minimum shifts. And note that when measuring the velocities, the machine uses the same Doppler shift formula, same this one, and plugs in the angle transmitted and the transmitted frequency and the reflected frequencies into it, so that it calculates the velocity of the blood. And in this example, it shows the importance of the angle. So the first picture, the vessel runs perpendicular to the color box here. Therefore, the Doppler shift is poor, like you are seeing some faint signals. The color box is the area where evaluation of the flow is performed, this one, and it also tells the direction of the beam. And you can steer this color box in different directions. So here now you change the direction of the color box. That means you change the direction of the ultrasound beam, and you can note that the color image has significantly improved. Now it's more uniform, and this is the direction of the beam, and this is the direction of the blood flowing towards the beam, and this is the angle between the beam and the vessel. So it's less than 90 degrees, and your flow has improved. And instead of changing the beam of the ultrasound by steering the box, you can also change the direction of your vessel related to the color box, which you can do by trying the different angles of the transducer. So whatever you do, if you are able to achieve the angle less than 90 degrees, you will get a better Doppler picture. Let's talk about spectral Doppler in little detail. As I mentioned, spectral Doppler is used to measure velocities in the blood vessels. And there are two types of spectral Doppler, that is continuous wave Doppler and pulsed wave Doppler. So the first one, this is the continuous wave Doppler. CW Doppler or continuous wave Doppler utilizes separate transmitting and receiving piezoelectric elements. Remember, piezoelectric elements are essentially present in the probe, and they are the key elements that will make the sound waves and also listen back to the echoes. So we have two different piezoelectric elements, and which allow the probe to continuously emit a single frequency and also receive continuously the reflected echoes from the sensitive region of the beam. But note that the sensitive area of the beam can be large, and therefore continuous wave Doppler will simultaneously detect blood flow in all the vessels in its pathway. So for example, if there are two blood vessels here, and the continuous flow Doppler is utilizing these waveforms, and because these two blood vessels are in the pathway of the ultrasound beam, this will measure the velocities in both these blood vessels. That means this type of Doppler is unable to provide information about the depth from which the Doppler signal is returning, but at the same time it is more accurate in identifying the velocities. So this modality is particularly useful in echocardiography, where you want to study flow across the walls. When you choose this mode, a Doppler line appears, like this green one, indicating the path of the Doppler beam, and the machine displays the velocities in that area in the form of a graph. And the pulsed wave Doppler now utilizes only one piezoelectric element. Instead of two separately receiving and transmitting elements, here there is only one piezoelectric element, which emits the ultrasound pulse and waits and listens back to the echo. So emits, waits, receives, and waits again. So it's like pulsing the waves. That's why it's called pulsed wave Doppler. And as every emitted pulse is paired with a corresponding return signal, it is possible to determine where the reflection has occurred and calculate the depth of the reflector. We can also define a distinct region of interest or sample volume to display the returning signals from specific regions. And means even though there are these two vessels in the pathway of this beam, you can ask the machine to measure the velocities only at this particular point of this vessel when you're not interested in knowing the velocities in this blood vessel, and also when you really want to know from what depth the signal is coming. So it's more accurate when you want to measure velocities from specific blood vessels. So let's take a little closer look at this thing. Say you want to measure velocities in the main renal artery, and this is the transverse view of the kidney, this nice C-shaped thing, and in the hilum there are renal vessels. So blue thing is, this is the main renal vein, and the red thing is the renal artery. And when you turn on the pulse wave mode, a Doppler line appears like the continuous wave Doppler. But here it's not very clear, but that's why I showed it in illustration here. So you get a dotted line like this, that's the Doppler line. And the difference between the continuous wave Doppler's Doppler line and this pulse wave Doppler line is that this one has a small opening. This is called the Doppler gate or the sample gate. So this should be placed on the blood vessel of interest, and the gate size can be adjusted as needed. And you should try to put the gate in the center of the vessel. So essentially the main difference is that in these two modes, when you turn each of them, for the continuous wave you just get this dotted line, and for the pulsed wave you get a dotted line with a gate in between. And now the machine displays a graph of velocity over time. So on the y-axis it's velocity in centimeters per second, and on the x-axis it's time. And you have a baseline here. And above the baseline is flow towards the transducer, and below the baseline is flow away from the transducer. And in this image, there are little bit of spikes in the below the baseline region. They probably represent velocities from the overlapping renal vein. And from this graph, you'll know the peak systolic velocity. This is the top part of this peak, and the end diastolic velocity, where is the lowest point of this waveform. As we discussed, the angle between the ultrasound beam and the blood flow plays a key role in accurate depiction of the velocities. As the angle approaches 90 degrees, the detected Doppler shift becomes minimum. So when you have a probe at 90 degrees to the blood flow, you pretty much don't detect any Doppler flow. And when the angle is lower, you get good flows. And as the angle increases, the detection will sometimes the detection can be higher also, but overall there will be inaccurate velocities. And these waves above the baseline tell you that the blood is in the direction of the transducer, and velocities that are being displayed below the baseline will tell you that the blood is going away from the transducer. To display the correct blood velocity, it is necessary to perform angle correction. When you activate angle correction, a line appears centrally in the Doppler gate. So when you turn on the angle correction, so this is your Doppler line, this is Doppler gate, you get this line in the gate that is called angle corrector or cursor. So what you do is you have to align this line parallel to the vessel wall like this. This is the vessel wall, and you should align this angle corrector parallel to the vessel wall. Here in this picture, you are able to see the Doppler line, gate, and angle corrector here, which is parallel to the vessel wall. And the machine then determines the insonation angle, allowing the detected Doppler shifts to be translated into velocities by plugging all these things into the formula. And this kind of angle correction here is wrong because your angle corrector or the cursor is not parallel to the vessel. You're your vessel wall is here, and you put it somewhere here with some angle, and whatever velocities you get using this kind of angle correction would be wrong. So the next question is, when is the angle correction important for our point of care purposes, especially from the nephrology standpoint? It's important when you are evaluating renal arteries for stenosis. But comprehensive renal artery evaluation is beyond the scope of point of care nephrology ultrasound. If you see usual outpatient appointment time for single study, it ranges from 60 to 90 minutes, which essentially tells you that it can be very time-taking examination, and also the patient needs to fast. All these things are not possible when you're quickly doing point of care ultrasonography in inpatients to use as an adjunct to your physical examination. You don't have that much time to completely evaluate renal arteries using Doppler. And the second thing is, if you are evaluating the arteriovenous fistula or graft, yes, then angle correction is important. So in your point of care practice, you might want to evaluate AV fistula for maturation and also see if there are any major issues with the flow. So for this purpose, you need to keep in mind the angle correction. So when is angle correction not important? Good news is that for most of the point of care ultrasound applications we perform, angle correction is not important. Angle correction is not required when your evaluation is not dependent on the absolute numbers of the velocities, but you're more dealing with the ratios or just the flow patterns. So when you're just interested in knowing if there is flow, for example, you want to know if there is a vessel in the needle path during kidney biopsy, you don't need angle correction. Actually, for that matter, you don't even need to use the spectral Doppler. Just the color Doppler will tell you if there is flow or not. And when you are evaluating for renal or portal venous congestion, we are just looking for the waveform here, how the waveform looks like, what's the shape of it, such as discontinuous or continuous patterns. And so we are not in need of calculating velocity. So there is no point in angle correction here. And when you are measuring renal resistive indices, because the resistive index is a ratio, angle correction does not play a major role. So what is resistive index? As you know, this parameter is commonly used in the sonographic evaluation of renal transplant. We saw that the pulse wave Doppler gives a graph showing peak systolic and end diastolic velocities like this. Peak systolic, this is end diastolic. And resistive index is calculated by the formula peak systolic velocity minus end diastolic velocity divided by peak systolic velocity. That is big number minus small number divided by big number. And normal resistive index is somewhere between 0.55 and 0.7. There is a general agreement that 0.7 should be considered the upper limit of normal in adults, but not in children, in whom renal resistive indices typically show higher values, especially within the first year of life. Also, renal resistive index has been reported to increase in the healthy elderly population, possibly because of age-related changes in vascular compliance. And with respect to renal allograft evaluation, we consider values more than 0.8 to be abnormally high. The utility of resistive indices is controversial because of non-specific nature, and but they do help when interpreted along with pertinent clinical and laboratory data. Too low values may warn you about possible problem with vascular anastomosis. Too high values may suggest rejection and prompt early biopsy. But note that they can be high essentially in any intrarenal cause of AKI, such as acute tubular necrosis. An NEJM article published in 2013 reported that allograft recipients with a resistive index of at least 0.8 had a higher mortality than those with a resistive index of less than 0.8 at 3, 12, and 24 months after the transplantation with hazard ratio of 5.2, though there was no difference in need for dialysis or no association with histologic features. And another study in NEJM published 10 years prior to this study reported that resistive index of 0.8 or higher measured at least 3 months after transplantation is associated with poor subsequent allograft performance and death. So it's kind of important to know the limitations and uses of resistive index rather than just blindly depending on a particular number. This is the illustration demonstrating renal vasculature. You have the main renal artery. It divides into big segmental branches, which divide into interlobar blood vessels, and interlobar blood vessels become arcuate vessels here, and you have small cortical branches coming from the arcuate arteries. And resistive index is typically measured in arcuate arteries here at the corticomedullary junction, or like pretty much close to the medullary wall somewhere here. And some authors suggest using bigger interlobar arteries for better reproducibility and ease of calculation. So you bring your Doppler gauge to either of these blood vessels, and usually average of 3 readings is taken, usually upper arcuate, middle arcuate, and lower arcuate vessels. And as mentioned before, Doppler angle is not important unless you want accurate and absolute values of the velocity. So you bring your Doppler gauge to these vessels here, one of these vessels, this or this, and the machine gives you the graph. The first step in getting resistive index is to get a good color image of the kidney. It's not always possible to obtain pretty pictures like this, but you should be at least able to get some blood flow in the medullary region. That way you know where to put your Doppler gauge. So this is an example of renal resistive index measurement. Here this white line is the Doppler gauge. It's not clearly visible, but the white line is here, and you put the gauge in the superior arcuate vessel. That is superior arcuate artery. And this part is towards head, this part is towards feet. And the machine will calculate the resistive index for you based on the peak systolic and end diastolic velocities. And here, in this case, the resistive index is 0.79. And here, this is the Doppler gauge is here, somewhere in the middle of the kidney. So it's measuring resistive index in the middle arcuate artery. And the machine says it's 0.82. And here, the arcuate artery that we are measuring in is in the lower pole, that is lower arcuate artery. This is just mislabeled as mid, just ignore it, but it is the lower arcuate artery, and the machine is saying based on the peak systolic and end diastolic velocities, the resistive index here is 0.78. This is essentially a renal allograft with mild hydronephrosis, so resistive index were slightly on the higher side. You see this, like, collecting system is slightly prominent. And so after resistive indices, I just wanted to show you how a fistula looks like inside the kidney, which is well pertinent to the point of care ultrasonography. So this is the renal sonogram, allograft sonogram in a patient who underwent biopsy 4 months ago. And the grayscale ultrasound looks okay, nothing really abnormal on this one. But when you turn on the Doppler mode, it demonstrates prominent vascularity and turbulent flow with all this mixture of colors in the lower pole, which is suggestive of arteriovenous fistula, probably involving segmental and interlobar blood vessels. And the transverse section of the kidney is in the inset here, and this nice colorful appearance sometimes is called confetti-like appearance or confetti sign, like this. And when you turn on the pulsed wave Doppler, you can see high velocities and a kind of disturbed flow without a specific peak of these waveforms here. And I showed a pulsed wave graph of the normal arcuate vessel for comparison of velocities. Here the highest velocity scale is 40, here it's 100, so there are definitely higher velocities. And the waveform is not distinct and well defined like this. And the cursor is somewhat here, the Doppler gauge is somewhat here, but if we place the Doppler gauge here, like in the middle of this area of turbulence, probably we could have got higher velocities than this. but the concept is the same. So you'll have essentially higher velocities and turbulent flow both on the color and pulsed wave. Arterial waveforms. Renal artery stenosis evaluation is beyond the scope of POCUS, but you need to know what information you can get from the waveforms when you are scanning the intrarenal vessels. Incidentally, you might discover one of these abnormal waveforms when you are looking for resistive indices. So first one is the normal waveform with nice systolic and diastolic waves here. This is the peak systolic velocity, this one, and this is the end diastolic velocity. And this pattern right here is the Tardus parvus waveform resulting from arterial stenosis. The phenomena is observed downstream to the site of stenosis. Say if the stenosis is here, you will see the Tardus parvus waveform here. And it is due to reduced magnitude of blood flow through the narrowed vessel during ventricular systole. So Tardus means prolonged systolic acceleration, that is slow upstroke. Here see the upstroke is like nice and brisk. Here it's slow, that's called Tardus. And parvus means small systolic amplitude and rounding of the systolic peak. See the amplitude here is much higher compared to this waveform. And during your renal sonogram, if you look at the blood flow in the distal vessels and it appears like this, there might be a problem proximally. And what if you see this kind of waveform while measuring your resistive indices? See here, there is no diastolic flow at all. This is a systolic wave here, and you see a big gap instead of diastolic flow. This kind of flow essentially indicates that there might be an obstruction downstream, and or the blood is not flowing during diastole, indicates distal obstruction. Always remember that distal disease increases resistance to flow, which means diminished diastolic flow and increased resistive index. And proximal disease or proximal stenosis decreases the strength of the signal. So you might encounter these waveforms incidentally, but they might point you in the right direction and helps you identify stenosis and order relevant investigations. So venous waveforms. Venous waveforms, we are typically interested in renal and portal venous forms. And here is the example of a renal venous waveform, which pretty much shows continuous flow with minimal variations. And these variations are secondary to respiration and right atrial pressure changes. And renal vein waveforms are typically used when you're dealing with congestive heart failure patient or essentially cardiorenal syndrome patient. You want to know if there is congestion in the renal veins. So as we saw, normal one is pretty much continuous with some respiratory variations, and these are all abnormal waveforms. The first one is called intermittent pattern, and it also has some short diastolic flow reversal. So this is vein, so this is the flow away from the transducer. So blue is away from the transducer, and whatever is on the color bar, top of the color bar is flowed towards the transducer. So because in the renal vein flow is away from the transducer, it will be depicted on the bottom side of the baseline. So here you see these small peaks on the above the baseline. These are short diastolic flow reversals. And this one here is biphasic interruption or flow reversal during same cardiac cycle. You have one stroke here, and there is flow reversal in the same cardiac cycle. And this is called the monophasic intermittent pattern. That means one forward and one reverse waveform. One forward, one reverse, one forward, one reverse. And all these waveforms were associated with increased risk of event in one study. Event meaning death or heart transplantation or hospitalization due to heart failure exacerbation. So you just need to be aware that continuous is good, and if you see some of the discontinuous patterns, it might not be a good waveform in terms of congestion. Now the portal vein waveform. So portal vein waveform is also used for the same purpose as the renal vein waveform, and it is very much similar to that. It's just a continuous waveform with slight phasic variations due to respiration and cardiac motion. Portal vein is usually red color in appearance because the way we hold the probe to get the longitudinal view of portal vein, the flow is towards the transducer. Again, on the color bar here, so whatever is on the top tells you that this flow is towards the transducer, and this one here is away from the transducer. That's why typically, unlike the renal vein waveform, you get above the baseline pattern for the portal vein. But if you want, depending on the direction of the flow, it can change, and also you can manually change above or below baseline waveforms. And these waveforms here are abnormal, and they show significant pulsatility in the portal vein circulation, which suggests cardiogenic portal vein hypertension. And this pulsatility in the second picture is significantly higher than this one, probably indicates more significant congestion. And cardiogenic portal hypertension can be secondary to pulmonary hypertension or right ventricular failure or even tricuspid regurgitation. One of the commonest indications of vascular ultrasound for nephrologists after resistive indices is to assess the maturation of arteriovenous fistula, which is relatively easy to do and can be done in your clinic instead of sending the patient to vascular surgery to make sure you can cannulate the fistula. So first examine the arteriovenous fistula as you would normally do. Again, a point of care ultrasonography is not a substitute for physical examination. It is an adjunct to physical examination. So inspect the body of the AV fistula to determine if it's visible, and if so, for what length. Optimal length is 6 to 10 centimeters. Assess its apparent diameter and depth to determine if it has the potential for being cannulated repetitively. And the optimal depth would be less than 1 centimeter of the skin surface on physical examination. I mean, depending on what you feel. And next, palpation. So gently feel for a pulse. Be careful in doing so, because if you compress the vein too hard, you'll create a spurious pulse. The pulse of the fistula should be soft and compressible. A strong thirsting pulse that is hyperpulsatility increases the presence of a downstream problem, that is in the direction of flow, creating increased resistance. If there is no thrill or pulse, the AV fistula may be thrombosed. And auscultation. It's helpful to listen to the bruit to determine the character of the diastolic component. The bruit should have a low rumbling pitch with a prominent diastolic component. With progressively increasing resistance, as with stenosis, this component occurring at the lowest pressure in the cardiac cycle will disappear first, and the lesion is present more downstream, that is in the direction of flow. Actually, in one study, experienced dialysis nurses were 80% accurate in predicting the usability of AV fistula for dialysis compared to ultrasound evaluation of AV fistula. So whenever you are in doubt, call your dialysis nurse to help you with the AVF examination. And so when you're doing the ultrasound examination, first get an idea of anatomy without using the Doppler. Just take a look at the fistula with grayscale ultrasound and get an idea of like what kind of anastomosis it is. In this image, it is side-to-end anastomosis, and in this image, it's side-to-side anastomosis of the vessels here. The superficial one is usually the vein, and the deeper one is the artery. And in this example, this is end-to-end anastomosis of the vessels, right here. And so how do we assess for AVF maturation? We follow a rule of 6, endorsed by the KDOQI guidelines 2006. That is, at 6 weeks post-creation, the depth of the fistula from the skin surface is less than or equal to 6 millimeters. And the diameter of the body of the fistula is more than or equal to 6 millimeters. And the blood flow rate should be more than 600 ml per minute. So everything is 6 here. So 6 weeks post-creation, less than 6 millimeters deep, and more than 6 millimeters wide, and more than 600 ml per minute flow. So how do we get the flow? Essentially, flow is the mean velocity in the blood vessel. Our pulse wave Doppler will give you the velocities, right? Peak systolic and end diastolic. So the machine will also give you the mean velocity from those things. And area. So what is the area of the circle here? If you take the cross section of this cylinder, it becomes circle, and area of the circle is pi r square. So that can be easily calculated by the machine, and you multiply it by 60 seconds to get everything into minutes in ml per minute flow. So here is an example. So this ultrasound of the arteriovenous fistula is of a recently created transposed basilic fistula. And the scale on the right of the image, this one here, shows you that if 5 millimeters length is superficial enough for easy cannulation here. So this is the distance from the skin surface to the outer wall of the fistula, that is less than 5 millimeters here, which is ideal. That means it's less than 6 millimeters based on your rule of 6. So this is a good depth. And the diameter of the blood vessel here is 0.73 centimeters. That means it is more than 0.6 centimeters or more than 6 millimeters, which is a good diameter. And the machine is also giving you the graph, and it says that the peak systolic velocity is 189.9 centimeters per second and end diastolic velocity is 123.9 centimeters per second. And now this blue line is the average velocity the machine used to calculate the flow. And plugging into the previous formula, the machine will tell you what is the total volume flow. In this case, it is 1792 ml per minute, which is way higher than your minimum flow of 600 ml per minute. So essentially this fistula is has good diameter of more than 6 millimeters. It's lying at a lower depth from the skin surface, less than 6 millimeters, and it has a great flow of 1700 ml per min. So it's usable for cannulation and a nicely maturing fistula. And if you want to evaluate the arteriovenous fistula stenosis, here are some basics. You probably don't want to undertake comprehensive evaluation of AVF yourself in the dialysis clinic, but it's good to know how common problems look like. So first take a look at the vasculature on the gray scale and identify where is the feeding artery, where is the anastomosis, and where is the outflow vein. And indicators of stenosis on Doppler exam are post-stenotic turbulence. Say if this area is stenosis, the circled area, after the stenosis, where the blood is flowing in this direction in the outflow vein, you have turbulence, here demonstrated by these mixture of colors. And when you turn on the pulse wave Doppler mode, you will find increased velocities, typically peak systolic velocity of more than 300 centimeters per second. And also compare peak systolic velocity at anastomosis to peak systolic velocity in the artery 2 centimeters upstream. So peak systolic velocity somewhere here to peak systolic velocity somewhere upstream here. This ratio more than 3:1 represents stenosis with diameter reduction more than 50%. So these are the characteristics of stenosis on Doppler exam. In general, the rule I follow is if blood flow is less than 500 ml per minute, send the patient for a fistulogram even if no anatomic etiology for the low blood flow is found. And in this example, a high-grade stenosis is noted just distal to the takeoff of a branch here, where elevation in both peak systolic velocity and end diastolic velocities is found. So here, just after the anastomosis, you are measuring the velocities, and they are so high. The peak systolic is 843 centimeters per second, and peak diastolic, end diastolic is 626 centimeters per second, both of which are way higher than your threshold of 300 centimeters per second. And Doppler color flow here demonstrates post-stenotic turbulence distal to the narrowest segment of the vein. So this is an example of high-grade arteriovenous fistula stenosis. And while doing this, don't forget about your Doppler angle. The angle of insonation, noted by the phrase SV angle here, on the upper right-hand corner of the image. Here in this image, it's 42 degrees. So it's good. It's less than 60 degrees. It's good. And the peak systolic velocity, that is highest point at the top of the waveform, is nearly 80 centimeters per second, this one. And note that the angle is correct here. So you have this Doppler line, you have this Doppler gate, and the angle correction cursor should be parallel to the vessel wall. In this image, it's not clearly visible. That's why I put this illustration here. So the angle cursor is parallel to the vessel wall, and the represented SV angle is less than 60 degrees. So this is a good thing. And in this example here, the same vessel is examined now at an angle of 70 degrees. So here see the angle, it says 70 degrees. And also marking the highest and lowest points along the waveforms instructs the machine to calculate peak systolic and end-diastolic velocity, shown in the lower left corner. Using this incorrect angle, the PSV has become more than double, that is 175.9 centimeters per second here. And note that it's the same example, same blood vessel. The line is pretty much appearing the same, but your angle corrector is not parallel to the vessel wall. That means overall the angle in the Doppler equation is changing, so completely changing the velocities. So here is 80 and here is 175 centimeters per second. That's how important it is, angle, if you really are dealing with the absolute values. Because you can say here the velocity is 80 centimeters per second, so it's probably okay. And here you jump and say, oh, velocity is like 175, it's significantly high. So an improper angle of insonation results in false impression of stenosis, where actually nothing, where there is no stenosis. What is aliasing? This is another important phenomenon you need to be aware of while performing Doppler evaluation of the high flow regions such as AV fistula. It's not uncommon to see this mixture of colors when you are evaluating fistula. See, this is not purely red or blue, but it's a mixture of colors indicating turbulent flow. This is called aliasing. Aliasing is commonly encountered artifact in color and spectral Doppler ultrasound, which is caused by blood flow velocity exceeding the upper limits of the scale set by the user. And see here the scale, the upper limit is 30 centimeters per second. So if your velocities in the blood vessel does not fall within range, then what happens is the peak of this waveform is cut off at the top of the scale, and that's represented below the baseline now. This is called aliasing. This is aliasing in the pulse wave Doppler mode. In the color, it appears like this. And similarly, you can use either of these modes to look at the aliasing. If you're calculating velocities, pulse wave Doppler becomes important. And these range of colors is like wrapping around. So if you look at the color bar here, so it wraps around all these colors. But note that there is no black thing here. So in this color bar, you have red, shades of red, shades of blue, and black separator. This kind of turbulence here, we call it wrapping around because it includes these colors, like these color scale wraps around this one. But if you see this black separator somewhere here in the flow, that means there is flow reversal, not just the turbulent flow or aliasing, but there is flow reversal. That's important, especially when you're doing carotid ultrasound. It's just something to note, probably not really important when you're doing AVF exam. So how to overcome this aliasing phenomena? One way is to increase the pulse repetition frequency, which increases the scale. Obviously, your problem is because you set the scale too low, right? Pulse repetition frequency is the number of pulses per second emitted by the pulsed wave Doppler. If you increase PRF, or the pulse repetition frequency, you will increase the scale automatically and the aliasing will decrease. See, in this picture, you note that you see aliasing here in the color picture. See this one mixture of colors? When the velocity is lower, unfortunately you are not able to see the exact values of the velocity, but when there was that mixture of colors, the velocity scale was low, and as the velocity scale was increased, and the flow has become more nicer and smoother in single color. So essentially increasing the pulse repetition frequency overcomes aliasing. And PRF can be different for color flow and pulsed wave, and it depends on in what Doppler mode you are evaluating. Other way to overcome aliasing is just to lower the spectral baseline. You are evaluating on only one blood vessel. So say you are evaluating the blood vessel where the flow is towards the transducer, so you are interested only in the waveform above the baseline. So if you just lower this baseline, this chopped off head of this graph comes back to the above the baseline without altering the pulse repetition frequency. You can try both these things and try to see if you can make the picture a little more of uniform color, and you get a better graph so that you calculate your velocities accurately. And how does the thrombosis look like? Here is an example of subclavian and axillary vein thrombosis in one of my CKD patients secondary to PICC line. Note that there is no color or Doppler, pulsed wave Doppler form here. See, this is the subclavian vein. If you closely observe, you will see the PICC line here. Nice straight thing. Here it's more clear, the PICC line inside the blood vessel. But there is no color flow. There is a color box here, but there is no flow. And even when you brought the Doppler line and the Doppler gate here, you are not seeing any meaningful waveform, which essentially indicates that there is the vessel is thrombosed. And here the brachial vein was okay, and jugular vein was okay. So essentially it's thrombosis in the subclavian and axillary veins, because of the PICC line. That's why we discourage the use of PICC lines in CKD patients. And this extremity may not be suitable for creation of AVF in the future, which imparts significant morbidity to the patient. Thank you, and if you have any questions or concerns, or if you want to share any interesting images, feel free to contact me on Twitter. And this is a dedicated Twitter handle exclusively for nephrology-oriented point-of-care ultrasonography. Thank you.